So today we're going to talk about shoulder injuries for this CEU class, and we're going to look at some common conditions. Hopefully you've already looked at the tutorial video, which is a separate video from this. You should have gotten an email link to that video. If you haven't gotten it, you can always email me at dr.joven@nmnm.org. This is just a good way to brush up before we start with this CEU class. And just a couple of recommendations before you start watching the whole video is that, take breaks whenever you need to. And also, you might want to just stop and pause the video in between each condition and then kind of repeat it with your partner or someone who's around you. Palpate, do whatever you like, and then start where you stopped and watch the video again, and do so throughout the whole video so that you don't watch the whole thing throughout. That way you will actually obtain the 4 hours that you need for this CEU class. Alright, let's get started. So here we have the anatomy of the shoulder. So the shoulder joint, which is the most movable joint in your body, is composed of 3 bones. We have the clavicle, the scapula, and the humerus. The shoulder can also be unstable because the ball of the humerus is just so much larger than the shoulder socket that holds it. So to remain stable or in normal position, the shoulder must be anchored by muscles, tendons, and ligaments. The shoulder has a series of joints which enable a large range of movement. So the 3 main joints, which are abbreviated in the blue letters in the picture, are the glenohumeral joint, the acromioclavicular joint, and the sternoclavicular joint. There is also another joint which is important in the shoulder movement, which is the scapulothoracic joint. Technically, it's not a joint, it's more of an articulation because it does not have a capsule or a ligamentous attachment. So this joint relies entirely on the surrounding muscles for its control. This joint can often obtain fibrous adhesions following a shoulder injury, which also can impair movement. Because the shoulder is unstable, it's the site of many common problems. So these include sprains, strains, or tears, dislocations, separations, tendonitis, bursitis, fractures, frozen shoulder, and arthritis. And we're going to look into all of these conditions today. So, what types of shoulder injuries do we have? Well, we have 3 main ones. We have soft tissue injuries, which are tears of the ligaments, tendons, muscle, and joint capsule of the shoulder, such as rotator cuff tears and labral tears. Second, we have dislocations, which occur when the bones on the opposite side of the joint do not line up. Dislocations can involve any of the 3 different joints. So a dislocation of the acromioclavicular joint is called a separated shoulder. A dislocation of the sternoclavicular joint interrupts the connection between the clavicle and the sternum. And the glenohumeral joint can be dislocated towards the front anteriorly or towards the back posteriorly. Lastly, we have fractures, which are broken bones. Fractures commonly involve the clavicle, the proximal humerus, and the scapula. So what activities can actually injure the shoulders? Usually the injuries in the shoulder involves the soft tissue more than the bones. Athletes are especially susceptible to shoulder problems. In athletes, shoulder problems can develop slowly through excessive, repetitive, overhead motion training routines, such as you see here, tennis or pitching. Some athletes, they would actually play through not really listening to the symptoms, and play through a shoulder injury, which only aggravates the condition and may possibly cause even more problems. People also may underestimate the extent of their injury because steady pain, weakness in the arm, or limitation of the joint will become almost second nature to them. Injuries can also occur during everyday activities, depending on what we work with, or washing walls, hanging curtains, and even gardening. So orthopedic surgeons group shoulder problems into following categories. When the shoulder joint moves or is forced out of its normal position, it's called instability and can result in a dislocation of one of the joints in the shoulder. Individuals suffering from an instability problem will experience pain when raising their arm. They also may feel as if their shoulder is slipping out of place. So the green arrows that you see in the picture to the left demonstrate the humerus gliding posteriorly and anteriorly. The second category is impingement. Impingement, as you can see in the picture to the right, is caused by excessive rubbing of the shoulder muscles and or bursa against the acromion. Impingement problems can occur during activities that require excessive overhead motions, and it's always advisable for patients to get treated immediately for the inflammation in the shoulder because it could eventually lead to more serious injuries. Okay, so here we have a rotator cuff tendonitis. Rotator cuff tendonitis and shoulder bursitis, which we will look into after this, are different ways of saying that there's an inflammation of a particular area in the shoulder. And this is causing common set of symptoms. However, the proper terminology for these symptoms is actually impingement syndrome. Impingement syndrome occurs when there's an inflammation of the rotator cuff tendons and the bursa that surround these tendons. In most cases of impingement syndrome, there is a combination of these problems. Impingement syndrome occurs when there's an inflammation between the top of the humerus and the acromion. So between these bones lies the tendons of the rotator cuff and the bursa that protects these tendons. So in normal cases, these tendons should slide effortlessly through the space. In some people, this space becomes too narrow for normal motion. And what happens is that the tendons and bursa become inflamed. Inflammation leads to the thickening of the tendons and bursa, and that contributes to less space in this location. So with time, this space becomes too narrow for the tendons and bursa, and every time these structures move between the bones, they are pinched, and so that's why the condition is called impingement syndrome. So what can cause this? Well, usually it's keeping the arm in the same position for a long period of time, such as doing computer work or hairstyling, playing sports again, such as tennis, pitching, in baseball, swimming, and lifting weights over the head. Anything that requires the arm to be moved over the head repeatedly will irritate it. And then, of course, working with the arm for many hours a day, painting or carpentry, sleeping on the same arm each night. And what we have to teach our patients is the whole posture. Poor posture, poor muscle control, coordination of the shoulder, or our bodies will irritate the shoulder and the shoulder blade muscles. So it's important to teach patients how to use their bodies. Usually we will see rotator cuff tendonitis in patients between ages 30 to 50 years. So what do they usually complain about when they come see us? Well, in an early stage, what will happen is that pain will occur with the overhead activity and lifting the arm to the side, abduction. Activities like, the brushing their hair or reaching for objects on shelves, or playing an overhead sport. So pain is more likely to be in the front of the shoulder, and it may radiate to the side of the arm. However, the pain always stops before the elbow. If it should travel beyond the arm to the elbow and hand, this may indicate a pinched nerve. So that's when we have to check, and see if we can treat the neck area as well. There may also be pain with lowering the shoulder from a raised position. So at first the pain may be mild and occur only with certain movements, but if you don't do anything about it, as time goes, it may present when they're at rest or at night, or especially when they're lying on their shoulder. They might experience some weakness or loss of motion when they're trying to do all these overhead movements, and they can feel stiff when lifting. So also what they can experience is that they hear like a clicking in the shoulder when they're raising their arms above the head. So how do we diagnose rotator cuff tendonitis? Well, of course, as always, we do the patient history. They will complain of the pain related to the symptoms that we just saw. And what you as therapists might find is that you have tenderness over the shoulder, or the patient has tenderness over the shoulder while you're palpating. And when you're taking muscle testing, there's usually weakness of the shoulder when it's placed in certain positions. Testing range of motion, the patients might feel pain when doing medial rotation and full abduction, or they can even have a positive painful arc. Through Apley's test, you can evaluate the patient's active range of motion, which is a good way to really quick find out their range of motion by, first of all, letting the patient reach for the upper part of the scapula behind their back on the opposite shoulder, and then try to reach for the lower part of the scapula, and lastly try to reach for the acromion or shoulder in the front of their bodies on the opposite side. With drop arm test, you let the patient abduct their arm to a 90-degree angle, and let the patient slowly, like with straight arm, lower it to down. And if the patient is having trouble with the movement, or dropping the arm, it may be an indication of a problem with the supraspinatus. Another test is the empty can test for supraspinatus, where you perform an isometric test when the patient has both arms in a 90-degree abduction, and afterwards you rotate the patient's shoulders immediately about 30 degrees, so that the patient's thumbs are pointing towards the floor. And the resistance to abduction is again given while looking for weakness or pain, which is an indication for a positive test. If it's persistent in the shoulder, another way, if it's been going on for quite a while, X-rays of the shoulder may show if there's any bone spurs that is irritating the area, or the MRI might show a swelling or tear of the rotator cuff. So once we've established that this patient is suffering from a rotator cuff tendonitis, how do we treat it? How do we approach it? Well, for once, we got to tell the patients to stop or decrease whatever activity irritated the shoulder. They should also try to eliminate the inflammation by trying to apply ice on the affected area for about 20 minutes, 3 to 4 times a day. If, however, the pain is too much for the patient to handle, they can try to take anti-inflammatory medications to reduce the inflammatory condition. They should begin an exercise program to maintain the flexibility, and also stretching while in a pain-free range is crucial so that they keep moving it, keep the circulation going. Even daily stretching while they're taking a shower is really beneficial. If the shoulder becomes more severe, prescription strength medication or a cortisone type injection may be of help. Not in our range of in our scope of practice, but however, when you use the injection should be done in conjunction with the home exercise program to maintain flexibility and to strengthen. For a young patient like under 30 and the first episode of rotator cuff tendonitis that is treated immediately with this type of approach, the average length of the time for rehabilitation is about 2 to 4 weeks. So that's why it's crucial to just treat the patient right away. For those with recurrent episode of tendonitis and some risk factors, rotator cuff tendonitis may take months to heal and in rare cases may require surgery. If the symptoms persist, surgery to remove a spur on the acromion to increase the space can prevent further irritation or a complete rupture. So if an MRI shows a complete muscle injury, the surgical repair may be required. Okay, so as we saw with the rotator cuff tendonitis, the same thing happens with the bursa. And again, in many individuals with this problem, the shape of their bones can be as such that they have less space than others. So therefore, like just a small thickening of the tendons or the bursa can cause symptoms. Often there is an initial injury that sets off the process of inflammation. Thereafter, the problem can be self-exacerbating. Once there is an initial injury, the tendons and the bursa become inflamed. The inflammation causes a thickening of these structures. The thickening then takes up more space, and therefore the tendons and bursa become impinged even more. So this causes more inflammation and the more thickening of the bursa and tendons and so on. So what are the symptoms for bursa? Well, again, it's pretty much similar to that of a rotator cuff tendonitis. And the patients might, feel pain with overhead activities while they're sleeping at night, and they'll have pain on the outside of the shoulder or upper arm. So just as with rotator cuff tendonitis, we diagnose a bursitis by taking a patient history and a physical exam. Making an accurate diagnosis is necessary for the right approach, a proper treatment. So subcoracoid bursitis may limit full abduction, and the subacromial bursitis may limit a lateral rotation because of compression or pinching of these structures. X-rays, as you saw, usually perform to assess if there are any bone spurs of the shoulder, and MRI shows the soft tissue, and to ensure that there's no actual rotator cuff tear. So treatment, basically again the same as rotator cuff tendonitis. The first step of the shoulder bursitis treatment is to decrease inflammation, avoiding the problems that cause inflammation. Best rule of thumb to follow is if it causes pain, don't do it. And again, tell the patient to rest, put eyes on it. They can try anti-inflammatory medications, Advil, Aleve. All of these are the non-steroidal anti-inflammatory medications. And then again, some simple exercises include strengthen rotator cuff and help the shoulder move more efficiently. And this helps the patient to return to normal activities without pain. And also, don't tell them to not try to sleep on the arm that they're feeling pain in. Sometimes they don't even think about that. And again, should this not help, the next step would be cortisone injection, which is not popular, but could be a way to help the patient if they're in severe pain. Of course, we as naturopaths can treat with deep tissue treatment, stretch, mobilization, ultrasound, stim, just to help the circulation and ease up that inflammation. So patients who are considering surgery, though, as the last resort, they should at least have tried the non-surgical treatments for 3 to 6 months, and if there is no improvement, they should discuss further with their orthopedic surgeon. Next condition, we have a bicep tendonitis, which is an inflammation in the main tendon that attaches the top of the bicep muscle to the shoulder. The most common cause is overuse from certain types of work or sport activities. Athletes who throw, swim, or swing a racket or club are at greater risk. Bicep tendonitis may develop gradually from the effects of wear and tear, or it can happen suddenly from a direct injury. The tendon may also become inflamed in response to other problems in the shoulder, such as rotator cuff tear, impingement, or instability. Examination of the tissues in these cases commonly shows signs of degeneration. Degeneration in a tendon causes a loss of the normal arrangement of the collagen fibers that join together to form the tendon. Part of the tendon tissue becomes kind of mixed up or scrambled up due to this degeneration. Other fibers, they might break, and that causes the tendon to lose its strength. When this happens, what happens in the bicep tendons is an inflammation, or even a rupture of the bicep tendon may occur. A bicep tendonitis can happen from a direct injury, such as a fall onto the top of the shoulder. A torn transverse humeral ligament can also lead to bicep tendonitis. If this ligament is torn, the bicep tendon is free to jump or slip over the groove, and so it irritates the tendon and eventually causes it to be inflamed. The symptoms that we can see or hear a patient complain about is that they might feel pain or tenderness in the front of the shoulder, which worsens with overhead lifting or activities. Pain or achiness that moves down the humerus can also um, be present, as well as inflammation and swelling with an occasional snapping sound or sensation in the So how do we diagnose the bicep tendonitis? As always, we always take this patient history, but the most common isolated clinical finding in bicep tendonitis is tenderness with the arm in a 10 degree of internal rotation. Patients with bicep tendonitis often complain of deep throbbing ache in the anterior shoulder. The pain is usually localized in the bicipital grove and may radiate down towards the insertion of the deltoid muscle or down to the hand in a radial distribution. This makes it difficult to distinguish from pain that is secondary to impingement or tendonitis of the rotator cuff or cervical disc disease. Pain from bicep tendonitis usually worsens at night, especially if the patient sleeps on the affected shoulder. Repetitive overhead arm motions, pulling or lifting may also initiate or exacerbate the pain. The pain is almost noticeable in the follow-through of a throwing motion. For the speed test, as you see in the picture, the patient tries to flex the shoulder against resistance with the elbow extended and the forearm supinated. A positive test is pain radiating to the bicipital grove. If any of these tests is positive, it indicates that impingement is present, which can lead to a bicep tendonitis or tendinosis. Lippmann's test is when you hold the patient's arm in a 90-degree angle and palpate the bicep tendon below the glenohumeral joint, and you go from side to side in the grove. So a sharp pain indicates a positive test and the bicep tendonitis. Other tests you can do are Jorgensen, Neer, and Hawkins. So treatment for bicep tendonitis usually begins with resting the sore shoulder. Also avoid the sport activity that led to the problem. Resting the shoulder relieves pain and calms inflammation. And as we saw with the rotator cuff tendonitis and bursitis, we can apply ice 20 minutes at a time, about 3 to 4 times a day to keep the swelling down. Same thing here with the anti-inflammatory. Patient can take anything from ibuprofen to Aleve, and when present, condition causing the bicep tendonitis are also addressed. For example, like if there's a shoulder impingement, it may require specialized hands-on joint mobilization, along with strengthening of the shoulder, of the rotator cuff and shoulder blade muscles. Treating the main cause will normally get rid of the bicep tendonitis. When needed, we should also evaluate the way the patient works or do their sport activities to reduce problems of overuse. And in rare instances, there might be a need for a cortisone injection. However, these are very powerful steroids, and you don't want to weaken the tendons and may possibly cause it to rupture. And specific strengthening and stretching exercises will restore range of motion and strengthen the shoulder. And you can see a picture here, or a couple of pictures to the right. There are some examples that you can give patients to strengthen their bicep. Let's move along to rotator cuff tears, and let's just repeat a little bit, do a little bit of repetition about the rotator cuff. So as you know, your arm is kept in your shoulder socket through the rotator cuff, and it's a network of muscles that come together as tendons to form a covering around the head of the humerus. These muscles are the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. The rotator cuff attaches to the humerus, to the shoulder blade, and helps lift and rotate your arm. The bursa between the rotator cuff and the acromion allows the rotator cuff tendons to glide freely when you move your arm. When the rotator cuff tendons are injured or damaged, this bursa can also become inflamed and painful, as we saw in the bursitis slides. The rotator cuff muscles provide individuals with the ability to lift their arm and reach overhead. When the rotator cuff is injured, people sometimes do not recover the full shoulder function needed to properly participate in an athletic activity. A rotator cuff will weaken your shoulder, or a torn rotator cuff will weaken your shoulder. This means that many daily activities like combing your hair or getting dressed may become painful and difficult to do. So when one or more of the rotator cuff tendons is torn, the tendon no longer fully attaches to the head of the humerus. Most tears occur in the supraspinatus muscle and tendo, but other parts of the rotator cuff may also be involved. In many cases, torn tendons begins by fraying. As the damage progresses, the tendon can completely tear, sometimes when lifting a heavy object. There are different types of tears. There is a partial tear, and this type of tear damages some portions of the soft tissue, but does not completely sever it or extend all the way through, as you can see in the picture to your left here. To the right, you see an example of a full thickness tear. This type of tear is also called a complete tear. It splits the soft tissue into two pieces. In many cases, tendons tear off where they attach to the head of the humerus. With the full thickness tear, there is basically a hole in the tendon. There are two main causes of rotator cuff tears: injury and degeneration. An acute tear is if you fall down on your outstretched arm or lift something too heavy with a jerking motion, such as when people do heavy lifting, you can tear your rotator cuff. This type of tear can occur with other shoulder injuries, such as a broken collarbone or a dislocated shoulder. Most tears are the results of wearing down of tendon that occurs slowly over time. This degeneration naturally occurs as we age. Rotator cuff tears are common in the dominant arm. If you have degenerative tears in one shoulder, there is a greater risk for a rotator cuff in the opposite shoulder. And even if the patient have no pain in that shoulder. So several factors contribute to degenerative or chronic rotator cuff tears. We have repetitive stress. Repeating the same shoulder motions over and over again can stress the rotator cuff muscles and tendons. And again, as we've seen over and over again, it's everything from baseball, tennis, and weightlifting, and even many jobs and routines that requires overhead use of our shoulders and arms. Lack of blood supply. As we get older, the blood supply in the rotator cuff tendons lessens. So without a good blood supply, the body's natural ability to repair tendon damage is impaired. This can ultimately lead to a tendon tear. As we age, bone spurs often develop on the underside of the acromion bone. So when we lift our arms, the spurs rub on the rotator cuff tendon. And as we saw before, this is what's called shoulder impingement, and over time it will weaken the tendon and make it more likely to tear. We have different grades of strains. So grade 1 strains involve stretching of the fibers without any tears. Grade 2 injuries involve partial muscle and tendon tearing, and grade 3 injuries are defined as complete tear of a muscle or a tendon. So what are the risk factors when it comes to rotator cuff tears? Well, because most rotator cuff tears are largely caused by normal wear and tear that goes along with aging, people over 40 are at greater risk. People who do repetitive lifting or overhead activities are also at great risk of rotator cuff tears. Athletes are especially vulnerable, especially if they play tennis, baseball, if they're baseball pitchers, and professions like painters and carpenters that require a great deal of overhead work. Although overuse tears caused by sport activities or overhead work also occurs in younger people, most tears in young adults are caused by traumatic injury like a fall. So what are the symptoms and findings of a rotator cuff tear? The most common symptoms and what we can find include pain at rest at night, particularly if lying on the affected shoulder, pain when lifting or lowering the arm, or pain with specific movements, weakness when lifting or rotating the arm, and sometimes you can't even use some of the muscles because of a complete tear. There's bruising and swelling, and the crackling sensation when moving the shoulder in certain positions. So how do we diagnose a rotator cuff tear? As usual, we take the patient history, and the physical examination can involve observation to look for deformities, muscle wasting, changes in appearance of the damaged shoulder compared to the normal one. Palpate the bones, palpate the muscles, and assess the range of motion. The range of motion can be done both passively and actively. This part of the examination may, however, be delayed or not done at all if a broken bone is suspected. The power of the shoulder muscle can also be assessed in this way depending on whether the patient can actually move against resistance or perhaps just lift the arm up against gravity. So sensation and blood flow in the arm and the hand may be assessed. Feeling for pulses and determining if there is a normal light touch, pain, and vibration sensation in the extremity. The neck may also be examined depending on the age of the person, the cause of the injury, and the symptoms to make certain that the pain in the shoulder is not referred pain from conditions of the cervical spine. So you may also ask about the chest pain or trouble of breathing to make certain that the shoulder pain is not referred from the heart. So you can perform a variety of tests to decide which of the four muscles of the rotator cuff is injured or damaged. Each uses muscle contraction to find the weak or painful muscle. Examples of the tests can be the drop arm test, as we saw earlier, which is a test for the supraspinatus, where the patient is asked to abduct his straight arm and lower it slowly. And if he can't do it smoothly, or if he drops his arm, it might be a problem with supraspinatus muscle. Another test for this particular muscle is the Job test. And you can see the picture here on your right, which is the first one at the very top. The Pate test is the test for the infraspinatus and teres minor muscle, which you can see in the middle. And the very last picture is the Gerber test for the subscapularis muscle. So if you have a rotator cuff tear and you keep using it despite increasing pain, you may cause further damage to it. So always tell it to your patients. And the tear can get even larger over time. Again, tell the patient to rest and ice it. And again, use 15-20 minutes periods at least 3 to 4 times a day. A sling may be helpful to rest the shoulder, but care must be taken not to wear the sling for too long, otherwise the shoulder joint will become stiff and may require significant effort in regaining the lost range of motion. So tell the patients that as well, educate them. Again, anti-inflammatory is also a remedy if the patient is experiencing too much pain. Specific exercises can restore movement and strengthen the shoulder. The program should include stretches to improve flexibility and range of motion. And to your right here, you have examples of a sheet of shoulder exercises that you can give your patients. So continued pain is the main indication for surgery, especially if the patient is very active and uses his or her arm for work or sports activities. Other signs that surgery may be a good option is if the symptoms have lasted more than 6 to 12 months, if there's a large tear, meaning more than 3 centimeters, if there's a significant weakness or loss of function in your shoulder. The tear, if it was caused by a recent acute injury. And surgery to repair a torn rotator cuff most often involves reattaching the tendon to the head of the humerus bone. Now let's continue with dislocation of the shoulder, and more so the glenohumeral joint. There are 2 ways the glenohumeral joint can dislocate: anteriorly or posteriorly. Anterior dislocations of the shoulder are caused by the arm being forced or twisted outward, external rotation, when the arm is above the level of the shoulder. These injuries can occur from many different causes, including a fall or a direct blow to the shoulder. Posterior dislocations of the shoulder are much less common than anterior dislocations of the shoulder. Posterior dislocations often occur from seizures or electric shocks when the muscles of the front of the shoulder contract and forcefully tighten. So what can we find during a shoulder dislocation? Well, physical examination should begin with observation of the 2 shoulders, comparing the sides, which may reveal bruising, swelling, edema, or obvious deformities on the affected side. Any atrophy of the muscles of the rotator cuff and upper arm should be noted. With the glenohumeral dislocation, a dimple in the skin occurs below the shoulder joint and the head of the humerus that can be palpated. Active and passive range of motion, shoulder range of motion, should be tested, and any restrictions or hypermobility should be noted. Attempting to move the arm in a throwing motion may reveal abnormal shoulder function and cause a high level of anxiety, sort of a positive apprehension sign. Lower arm pulses, like distal arm pulses, may be faint and there may be sensory changes. So the initial treatment of a shoulder dislocation involves reducing the dislocation, kind of putting it back in the socket. This usually involves treatment in the emergency room. The patient is given some mild sedation and pain medicine, usually through an intravenous line. Often the physician will pull on the shoulder until the joint is realigned. And this is confirmed on an x-ray, and the shoulder is then placed in a sling or a brace. X-rays will also show if there's any fractures, and the MRI is indicated to assess if there's any soft tissue injuries or if a tear of the rotator cuff is suspected. Thorough motor and sensory examination before and after the joint is restored to its normal anatomical position is important, since injuries to the axillary nerve can occur in up to 40% of the cases. So additional treatment at a later date is based on the patient's age, repeated dislocations, and the underlying associated soft tissue injury. Patients who are 25 or younger generally require surgery. Persistent instability of the shoulder usually requires surgery. And the surgery involves repair of the torn soft tissues. For chronic shoulder dislocations, you could use apprehension tests, as you see in the picture here, where the patient abducts his shoulder to a 90-degree angle, and you, as therapist, externally rotate the patient's arm. The patient will resist if he or she feels like the shoulder is about to dislocate. Moving on to dislocations of the acromioclavicular joint. Dislocations of the AC joint can be caused by a fall onto the shoulder or from lifting heavy objects. The term shoulder separation is not really correct because the joint injury is actually not the true shoulder joint. This dislocation usually occurs in male football players. AC joint injuries represent nearly half of all athletic shoulder injuries, often resulting from a fall onto the tip of the shoulder with the arm in adduction, or a direct blow to the acromion with the humerus adducted, as in collision in high impact contact sports. Injury may occur as a consequence of throwing sports or chronic irritation due to activities that require repetitive overhead motions, particularly weightlifting. So there are classifications of AC injuries. This is according to the Rockford classification. This is just so that you know that there are different types, but so there's everything from type 1, 2, 3, 4, 5, and 6. So type 1 is a joint sprained without tear of either ligaments. Type 2 is that the AC ligament is torn, but the coracoclavicular ligament is intact. So the lateral end of the clavicle is not elevated. Type 3 is when both the AC and the CC ligament torn. And you can see a little bit of an elevation of the AC joint. Type 4 is a lateral clavicle separated, and it's a little bit impaled posteriorly into the trapezial fascia. Type 5 is a complete separation of the clavicle and scapula with gross upward clavicular displacement. And the last one, type 6, is as type 5, but with the clavicle detached inferiorly and displaced behind tendons of the biceps and brachioradialis. So the symptoms and findings of an AC separation include pain at the moment the injury occurs, limited range of motion in the shoulder area because of the pain, not the weakness, swelling and bruising, and tenderness over the AC joint on top of the shoulder. There might be deformities depending on which grade the injury is. So if the outer end of the collarbone may look out of place, or there might be a bump on top of the shoulder, as you see in the picture here. Treatment options for AC joint separation. Treatment of the shoulder separation is based on severity of the injury as well as the direction of the separation and the physical requirements of the patient. Less severe shoulder separations are usually treated without surgery. Severe separations in an upward direction or dislocations in the backward or downward directions often require surgery. So surgery involves repair of the ligaments. So professional athletes and manual laborers are often treated with surgery, but the results are often unpredictable. So otherwise, again, you can try icing to calm down the inflammation, and it can be done for the first several days until the swelling around the joint has subsided. Rest the joint. A sling to rest the joint can be worn until the pain has subsided, and you can begin, or the patient can begin, some simple exercises. Resting the joint will help minimize painful symptoms and allow healing to begin. Also, again, anti-inflammatory medications such as Advil might help the inflammation. And depending on the severity of the AC joint separation, surgery might be considered. Let's look at fractures of the clavicle. Clavicle fractures are common injuries, and they can occur in different ways. Some patients fall on an outstretched hand, others fall and hit the outside of their shoulder, and it can also occur from a direct hit to the actual clavicle. In babies, however, clavicle fractures occur at birth during the passage through a birth canal. We have some risk groups that can injure their clavicle more easily. And those who have a low dietary intake of calcium and vitamin D may have a higher risk of clavicle fractures. Increasing the integrity of the bone by a sufficient amount of dietary calcium and vitamin D will help to prevent fractures in the bone. Also, sedentary individuals may be at greater risk due to weakness in the muscle stabilizers of the clavicle. Also, participation in extreme sports such as mountain biking and snowboarding will increase the risk of clavicle fractures as well. So what can we find during a clavicle fracture? Well, the usual symptoms such as swelling about the middle of the collarbone area, an area that may have a bump, which is actually the prominent ends of the fracture under the skin. The shoulder range of motion is limited, although not as much as with fractures of the proximal humerus. And the picture here demonstrates that little bump that you can see in a clavicle fracture. So most clavicle fractures can be treated without surgery. Surgery is necessary when there's a compound fracture that has broken through the skin or the bone is severely out of place. Surgery typically involves fixing of the fracture with plates and screws or rods inside the bone. This particular x-ray, I don't know how much you can believe Google or when you find these pictures, but this is actually a picture of Lance Armstrong's fixed collarbone. So let's look at fracture of the proximal humeral bone here. So proximal humeral fractures account for nearly 5% of all fractures and are the third most common fracture after hip fractures and distal radial fractures. A proximal humerus fracture results from a fall with an outstretched arm from standing height. In younger patients, high energy trauma is more frequent cause, and the resultant injury is more devastating. Additional mechanisms include violent muscle contraction from seizure activities or electrical shock and athletic injuries. Finally, a direct blow to the humeral or the proximal humerus, the head, may also lead to fracture. The proximal humeral fractures are usually classified by the Neer classification system. In the Neer classification of proximal humerus fractures, the proximal humeral is made up of 4 parts. It's made up of the humeral head, the articular surface of the head, the greater tubercle, the lesser tubercle, and the diaphysis, the shaft. The picture to your right here illustrates this classification. The typical signs and symptoms of a proximal humeral fracture include shoulder pain or upper arm pain, difficulty moving your arm and shoulder, swelling around your shoulder, bruising or discoloring around the shoulder and upper arm. And if you suspect that your patient has a proximal humerus fracture or any arm fracture, send them directly to a doctor or the emergency department so that they can have it ruled out with an x-ray. Because the risk is that there might be a permanent loss of function in the patient's arm. So a humeral fracture, proximal humeral fracture, can be treated with a sling and immobilization, and after a while definitely some physical therapy. Most fractures can be treated without surgery if the bone fragments are not shifted out of position. If the fragments are shifted, surgery is required, and it usually involves fixation of the fracture fragments with plates and screws or pins, or it can involve a complete shoulder replacement. So the treating surgeon, he must have an understanding of the fracture pattern, the quality of the bone, other patient-related factors, and the expanding range of reconstructive options. So next we have fractures of the scapula. Fractures of the clavicle and the proximal humerus can be caused by direct blow to the area from fall, collision, or motor vehicle accident. Also, an indirect fall on the shoulder can cause a scapular fracture. Because the scapula is protected by the chest and surrounding muscles, it's not easily fractured. Therefore, fractures of the scapula are usually caused by high energy trauma, such as high-speed motor vehicle accident. Scapular fractures are often associated with injuries to the chest. As with other types of fractures, scapular fracture may be associated with pain localized to the area of the fracture. Also, tenderness, swelling, and crepitus may be present. Since scapular fractures impair the motion of the shoulder, the patient will experience restricted range of motion. Bruising and bony deviations may also occur. Most fractures are diagnosed with x-rays of the area by a physical examination. Sometimes additional imaging techniques such as CT or MRIs are necessary to rule out any soft tissue tear. Non-surgical treatments with a simple sling works for most fractures of the scapula. An example is the one you see in the picture. The immobilization device holds the shoulder in place while the bone heals. Also, icing and pain medications can be used. The patient should start range of motion exercises within the first week of the injury. Other fractures may need 2 to 4 weeks of immobilization. A patient should begin limited active use of the shoulder immediately after the fracture. Passive stretching exercises should be continued until complete shoulder motion returns. This can take anywhere from 6 months up to a year. Certain types of scapular fractures may need further evaluation. Fractures of the glenoid articular surface, in which bone has moved out of place significantly. If there's fractures of the neck of the scapula, with severe angular deformities, fractures of the acromion process with impingement syndromes. In these instances, the patient may need surgery in which the doctor uses plates and screws to hold the bone together. But most fractures of the scapula can be treated without. About 10 to 20% of scapula fractures need surgery. Let's continue with frozen shoulder, which you probably often see in your practices. It's also called adhesive capsulitis, and it refers to a disorder in which the shoulder capsule, which is the connective tissue surrounding the glenohumeral joint of the shoulder, it becomes inflamed and stiff. And so it restricts the range of motion and causing chronic pain in the shoulder. So this extreme stiffness in the shoulder can occur at any age. It affects about 2% of the Americans, but most often it affects people between the ages of 40 to 60 years. Although the causes are not completely understood, it can affect people with diabetes, thyroid disease, heart disease, or Parkinson's disease. It can occur if the shoulder has been kept immobilized for a period of time, but also when a minor shoulder heals with scar tissue. That affects how the joint moves. The scar tissue reduces flexibility in the shoulder and makes it more prone to injury. The two major symptoms is the inability to move the shoulder in any direction without pain, with progressive loss of both active and passive range of motion. So pain and restricted range of motion. So one sign of a frozen shoulder is that the joint becomes so tight and stiff that it's nearly impossible to carry out simple movements such as raising the arm. The movement that is most severely inhibited is the external rotation of the shoulder. So a capsular pattern always indicates a lesion of the joint, whether its nature may be arthritis or capsulitis. So the capsular pattern of the shoulder is external rotation. That's the first movement that it will inhibit. Afterwards is the abduction. Lastly, it's the internal rotation. It may be either an acute synovitis or a chronic organized reaction of the fibrous capsule. The normal course of frozen shoulder has been described as having 3 stages. Stage 1 is the freezing stage or the painful stage, which may last from 6 weeks to 9 months, and in which the patient has a slow onset of pain. As the pain worsens, the shoulder loses motion. Stage 2 is the frozen stage, or adhesive stage, is marked by a slow improvement in pain, but the stiffness remains. The stage is generally lasts for 4 to 9 months. Finally, stage 3 is the thawing or the recovery stage, when the shoulder motion slowly returns toward normal. This generally lasts from 5 to 26 months. We can help a patient develop a stretching and exercise program and also incorporate deep tissue treatment. We could do ultrasound, ice, heat, and other modalities into the rehabilitation of frozen shoulder. It's important that patients perform their stretches and exercises several times a day, not only during the treatments. Again, anti-inflammatory medication, it hasn't really shown to significantly alter the course of the frozen shoulder, but it can be helpful, offering some relief from the painful symptoms. Cortisone injections are also commonly used to decrease inflammation in frozen shoulder joint. It is, however, unclear how beneficial the injection really is, but it can help decrease the pain, and as such allow more stretching and physical therapy. What is known is that the cortisone is only effective when used in conjunction with physical therapy and the management of the frozen shoulder. If, however, none of these treatments should help, occasionally a patient will need to have surgery. If this is the case, the surgeon may perform a manipulation under anesthesia. A manipulation is performed with the patient sedated, and the doctor moves the arm to break up adhesions caused by the frozen shoulder. This is not an actual surgery, meaning incisions are not made when a manipulation is performed. Most patients who have frozen shoulders will have slight limitations in shoulder motion even after the condition resolves. However, these limitations in motion is so minimal and often only noticed when performing a careful physical examination. The vast majority of patients who develop a frozen shoulder will recover their functional motion with therapy and stretching alone. Let's look at the osteoarthritis of the shoulder. There are 5 major types of arthritis that typically affect the shoulder. We're going to look into 2 of them a little bit more, and the 3 last ones, well, I'll just mention real quickly what that is. So let's start off with osteoarthritis, also known as wear and tear arthritis. Osteoarthritis is a condition that it destroys the smooth outer covering of the bone, the cartilage. As the cartilage wears out, it becomes frayed and rough, and the protective space between the bones decreases. So during movement, the bones of the joint rub against each other, and that's what causes the pain. Osteoarthritis usually affects people over 50 years of age, and it's actually more common in the acromioclavicular joint than in the glenohumeral joint. As with most types of osteoarthritis, pain is the key symptom. A person with shoulder arthritis is likely to have pain while moving the shoulder, as well as after moving the shoulder. The key, or the person can even have pain while they're sleeping. Another symptom may be limited range of motion. This limitation can be seen during both active and passive movements. Moving the shoulder might also produce a clicking or creaking noise. To diagnose shoulder arthritis, osteoarthritis, we take the medical history and, as usual, physical exam to assess pain, tenderness, loss of motion, and to look for other signs in surrounding tissues. At this point, you may be able to tell if the muscles near the joint has signs of atrophy or weakness from lack of use. Tests that might be ordered to diagnose osteoarthritis of the shoulder include x-rays, blood test. Blood test mainly to look for rheumatoid arthritis, but also to exclude other diseases. Removal of synovial fluid, which is the lubricating fluid in the lining of the joint, just for analysis, can also be one of the tests that you might want to order. And MRI scans is also an option. To diagnose shoulder arthritis, osteoarthritis, we take the medical history and, as usual, physical exam to assess pain, tenderness, loss of motion, and to look for other signs in surrounding tissues. At this point, you may be able to tell if the muscles near the joint has signs of atrophy or weakness from lack of use. Tests that might be ordered to diagnose osteoarthritis of the shoulder include x-rays, blood tests mainly to look for rheumatoid arthritis, but also to exclude other diseases. Removal of synovial fluid, which is the lubricating fluid in the lining of the joint, just for analysis, can also be one of the tests that you might want to order. And MRI scans is also an option. Rheumatoid arthritis, RA, it's a chronic disease that attacks multiple joints throughout the body. It is symmetrical, and so it usually affects the same joint on both sides of the body. It is an autoimmune disease. This means that the immune system attacks its own tissue. In rheumatoid arthritis, the defenses that protect the body from infection instead damages normal tissue, such as the cartilage and the ligaments, and soften bone. The joints of your body are covered with a lining, again the synovial fluid, and it lubricates the joint and it makes it easier to move. Rheumatoid arthritis causes the lining to swell, which causes pain and stiffness in the joint. So the most common symptoms of arthritis in the shoulder is pain, again, which is aggravated by activity and progressively worsens. If the glenohumeral shoulder is affected, the pain is centered in the back of the shoulder and may intensify with changes in weather. The pain of arthritis in the acromioclavicular joint is focused on the front of the shoulder. Someone with rheumatoid arthritis may have pain in all these areas if both shoulder joints are affected. And again, we have limited range of motion. It may be difficult to comb your hair or reach up to a shelf. And crepitus, again, the clicking sound. And as the disease progresses, any movement of the shoulder causes pain. And even night pain is common, and sleeping might be difficult. And the way of diagnosis of rheumatoid arthritis is the same as for osteoarthritis. And let's move on to the three last arthritic conditions that you can find in the shoulder. So I'm just briefly going to talk about these three conditions. The first one is the post-traumatic arthritis. Post-traumatic arthritis is a form of osteoarthritis that develops after an injury, such as a fracture or dislocation of the shoulder. Rotator cuff tear arthropathy is arthritis that can develop after a large, long-standing rotator cuff tendon tear. The torn rotator cuff can no longer hold the head of the humerus in the glenoid socket, and the humerus can move upward and rub against the acromion. This damaged the surface of the bones, causing arthritis to develop. So the combination of a large rotator cuff tear and advanced arthritis can lead to severe pain and weakness, and the patient may not be able to lift the arm away from the side abduction. Lastly, we have the avascular necrosis of the shoulder, which is a painful condition that occurs when the blood supply to the head of the humerus is disrupted. Because bone cells die without a bone supply, avascular necrosis can ultimately lead to destruction of the shoulder joint and arthritis. So these are the 3 other arthritic conditions in the shoulder. So how can treat these patients? So as with other arthritic condition, initial treatment of arthritis of the shoulder is non-surgical. So start off with rest or a change in activities to avoid and to provoke the pain is advisable. They might want to just change the way they move their arms and do things. And of course, exercises may improve the range of motion in the shoulder. So always give them exercises to strengthen and to stretch the area. Anti-inflammatory medication can help to reduce inflammation and pain again. And worst case, cortisone injections can help reduce the inflammation. However, it is often temporary. Moist heat or ice can also help. The recommendation is 20 to 30 minutes 2 to 3 times a day. You might want to help your patients with dietary supplements if you know much about that, such as glucosamine, and otherwise, if the pain is really severe, the other option would be surgical treatments if the pain is not relieved with the non-surgical options. Arthroscopy is when a surgeon kind of cleans out the inside of the joint. Although the procedure provides pain relief, it will not eliminate the arthritis from the joint. If the arthritis progresses, further surgery may be needed in the future, such as arthroplasty, which is a shoulder joint replacement. So this is the end of the CEUs for shoulder injuries, and if you do have any questions or comments, please email me at dr.joven@nmnm.org. I hope you found this interesting, and I hope to see you guys soon. Take care.